Hello, everyone, and welcome to part 2 of our series on the ABMRS. What does credentialing really mean for MR safety? Joining me today are a few very special guests. I have Dave Jordan, David Altman, and Kristan Harrington. And when it comes to MR safety, this is a highly qualified group I have with me. So I'm going to take a moment to let each of them give a brief introduction of themselves. Dave, do you care to go first?
Sure. My name is Dave Jordan. I am a medical physicist. I work for University Hospitals Cleveland Medical Center in Cleveland, Ohio, and I am a certified MR safety expert, and I'm currently the vice chair of the ABMRS.
Perfect. And to eliminate any confusion today, because we do have two Daves with us, next up is going to be David Altman. David, do you care to go next?
Thank you, Kellye, so much for having us, and happy Veterans Day. My name is David Altman. I'm a radiologist in a community practice in Charlotte, North Carolina. I'm certified as an MR medical director in MRMD, and I'm currently serving as secretary-treasurer of the ABMRS.
Perfect. And last but certainly not least, Kristan Harrington.
Well, thank goodness my parents chose to name me Kristan instead of David, so that eliminates confusion for the purposes of this. So, I'm Kristan Harrington. I'm an MR clinical educator. I'm also still a scanning technologist on a PRN basis. I'm also a credentialed MR safety officer, and I also serve as the chair of the MRSO ESC, the Exam Specification Committee. And thank you for having me today.
Yeah, well, thank you, each of you, for joining me. I thought it would be nice to get a group of people together, but not just any group of people. I wanted one of each of the credentialed personnel to join us so that we can go like a deeper dive into what does your day-to-day look like, and how do you feel like credentialing through the ABMRS has impacted MR safety at your facility, and even your own personal knowledge of MR safety and how you apply that. So I always think of an MRMD as the captain of the ship. This is who I think of as we're running the show. We're telling you within what parameters do we want you to practice and how to practice MR safety. So David, I'm going to let you start. From a credentialed personnel's perspective, how do you think this has changed your department or your approach to MR safety?
Well, thanks. I'll start out by saying that beyond my radiology training, I did not have any special or specific training before I got involved with this. I received the MRMD certification, I believe, in 2017, and I went on to serve as my institution's MR medical director for a number of years before someone else has now stepped into that role. But in the course of serving as MRMD, I asked a lot of questions, and I guess I showed enough interest or made myself enough of a nuisance that Bill Faulkner, a recent guest of yours, I believe, he invited me to get more involved. So that's how I got involved with the ABMRS. But to answer your question, when I became an MRMD, I found myself not only taking over that role, but helping our system transition to this new era in MR safety. So this was new for me and new for our local institution. So initially for me, it was a lot of learning and helping with redesigning policy and implementation. And I can talk a little more about how it changed the day-to-day on the department workings, but just talking about the day-to-day work for the MRMD, a lot of it is discussing specific issues that come up. Now, we don't have everything come to the MRMD. We have several excellent technologists with MRSO certification that are dealing with issues large and small every day, just like all technologists are. And when they need to contact a radiologist, we have a workflow where they will contact the appropriate subspecialty radiologist, just like they might with a question about IV contrast. Mm-hmm. But for very difficult or especially policy level questions that might impact the way we do everything, the MRMD may get involved. And another time when the MRMD will get involved, in my experience, is when we have serious safety incidents or near-miss incidents. And these need to be reported to the MRMD or the MRSO, the safety officer, in a timely manner. And then they will get reviewed in the MR safety committee. And I'll say one more bit about what this means for the hospital system and your place in the as a representative of MR safety in your group, it means you're the point person not only in your group, if you're a radiologist in your radiology group, but for the hospital system as a whole. So as the MRMD, this will put you in meetings with hospital administration, not only radiology hospital administration maybe, but overall hospital administration. And as a couple of examples, I would have meetings with the chief of medical staff and orthopedics about workflow related to implants. I met with the head of cardiac electrophysiology to discuss our policy about implanted cardiac devices. I remember I was contacted by risk management to help explain gadolinium deposition. Now, I am a person in community practice. I am not some national expert on GAD deposition or scanning pacemakers. I'm really not. But in this role, you can locally be really helpful because you can help spread good basic information that you have.
Yeah. Yeah, I think that's great. Kristan, I always think of the MRSO as like the boots on the ground, right? To me, the MRSO is, okay, now I've taken the MRMD's policies and procedures, and now I'm boots on the ground. I'm with the rest of the team. We've got to implement these. We've got to make sure that we follow these policies and procedures. So what, from an MRSO perspective, how do you feel like being credentialed has changed your department?
Okay, so there's two different paths that I look at here. So first of all, like next week, I'm doing a risk mitigation. Received a call and someone said, Kristan, we dodged a bullet. And I thought, oh gosh, there's so many guns in the MRI. Did they literally dodge a bullet? And so I called them, and fortunately that was just their saying, but they literally, it was unfortunate. The patient kept telling the technologist that they had a leg, a prosthetic that could not go into the MR. And the patient care tech aide, which we'll get to later, had screened the patient appropriately and told the technologist. Well, the patient actually had a full leg prosthetic with electronics that even made the toes move.
Wow.
Something that was extremely complex, and it pulled the entire leg off from the hip down. And pinned the technologist's hand to the magnet. So almost maybe, dodging the bullet was pretty much it. So from that perspective, they welcome me with open arms. And so this is two-tiered because I'm also a PRN technologist, very different approaches.
Yeah.
So I go in and then we help. Okay, and Bill goes with me many times. We go in and they want so much help. Yes, we will look at the organizational structure. We will create an MR safety team. What will happen is we will have a direct line. So we'll have an MR safety officer in place. No, we don't have someone credentialed, but we really want to look at doing that. They're going to go ahead and look at all these documents. They're going to get educated. Then they look to be credentialed. Then best case scenario, they are in that job full time. If there is something happens, someone called me yesterday. When you are a credentialed MR safety officer, you're on call 7 days a week. Someone called me from our hospital at Grady Hospital. That is the hospital you go if you have a head injury in Atlanta. It's the inner city hospital, but that's where I want to go if I've got an injury. They called me. They said they've got a Medtronic, this implant, and I'm having trouble getting information. So you're on call 7 days a week. And so you've got to be able to supply this information. So what comes into the department, if the technologist should be concentrating on the patient, they give it to the MR safety officer. The MR safety officer, and the way that I take it is I need to gather every bit of information possible. That is my job. That is like white glove service.
Yeah.
And then I take it to the radiologist. Now, I'm not always going to get Dr. Dave Altman. I'm not going to get him all the time. There are different types of radiologists, and I don't have to go into that detail at all. But I'm going to so I need as much information as possible because what my responsibility is not, he's going to determine safety.
Yep.
And then I am going to go back to the department and implement it.
Yep.
And I'm going to say, Dr. Dave Altman, I don't know how to differentiate between Dave squared on this. So I'm just going to say Dave Altman. Is that okay, Dave? Okay. All right. I just want to make sure everybody gets credit for what's said. And so then what I'm going to do is I'm going to take it back and I'm going to, say, this is what Dave Altman said that you're going to be doing.
Mm-hmm.
And they're going to go ahead and implement his orders because he has final determination.
Mm-hmm.
And hopefully he is a credentialed MR medical director
Yeah.
and MRMD.
Yeah.
Now, that is a direct line, the supervising radiologist and the MRMD. Now, if it's something behind the covers, then we're going to go to the MRSE. And I want to discuss one other thing. As a PRN technologist and as a travel technologist, as a PRN technologist going to multiple sites in my own experience, I go in and I see tensor barriers against the wall. I'm working alone. They have signs on the wall that say ACR with a signature. I have no radiologist to call. I put a tensor barrier up and the front desk asked me, what is that? They've never seen it used before. I had to resign, obviously, because a bladder stimulator, I was told by the front desk, we scan these. So I imagine someone that doesn't understand and doesn't have that education in MR safety might accidentally feel the peer pressure from other technologists that might not have that education, from people at the front desk that say they've always been scanned. Getting by with something does not prove safety. We all know that. Yeah. And that's when accidents occur. It's the Swiss cheese model. That's what it is. It comes down to that. And so I was one that could not be pressured. And because of that, safety, I did not have a situation. Yeah. I also didn't turn away patients that were able to be scanned. Yep. And so, a thing techs a lot of times love to say is no. Yeah. No. And so I was able to probably scan some patients that other people would have said, no, absolutely not. Because we know there's conditional tissue expanders now, right? We've got those out there. And so, you have to just know that things are constantly evolving. Yeah. And being a credentialed MR safety officer is a big part of that. Yeah. Kind of opens your world up. Yeah. But if it's something behind the covers, and trust me, at some of these PRN sites, it was behind the covers. I mean, whoa, was it behind the covers? We had to contact some people that were local. I live here in Atlanta, Georgia, and they were our physicists. And so I would like Dave Jordan, PhD, to would it be okay if he commented on that?
Yeah,
behind
absolutely.
the covers.
So the MRSE behind the scenes, the big watchword there for what does the MRSE do is to be a resource. I've found a lot of times it's getting people to look to me and say, okay, I don't understand some documentation, or I'm having a hard time, getting on the same page between our technologists, our radiologists, our other physicians. I spend a lot of time kind of trying to translate and facilitate those conversations just to get everybody to understand, okay, why are we concerned about this? How do we navigate when things aren't particularly clear? We run into a lot of situations, and everybody's seen this. You say, well, the patient has an implant, and we have this very, very detailed documentation from the medical device implant manufacturer. But when you read through it, it doesn't actually tell you how to scan it. It just says a bunch of engineering stuff. So, being able to kind of parse through that, and again, 90+% of this stuff doesn't make it to me because we do have, here we have very seasoned technologists who have seen most of this stuff before. So I get the weird stuff that hasn't come up before. And it's, what do we do with this? Or to try to work through it and try to get everybody to move a little bit. So we have radiologists who are concerned about how are we going to do this safely. And we have, referring services who insist we just absolutely must find a way to do this. Okay, well, somehow we have to make those things come together. So, facilitator, translator,
liaison,
phone call of last resort sometimes. And really a lot of it, a lot of what I find myself doing in my department isn't so much solving problems or giving people answers. It's really reassuring people of what they already know. The
Mm-hmm.
technology will say, I think I've got this figured out, but I want to make sure I've got it right. And I'll say, yeah, it looks good to me. Somebody will call for, a radiologist decision on something, and they'll page me and say, hey, just before I give this the go ahead, I just want to make sure I'm looking at this in a way that makes sense to you. So most of the time I just get to say, yeah, sounds like what I would do. So,
So Dave, who do you find that you're consulting more? Do you find that it's more physicians or technologists or equal parts both?
I would say it's more often technologists, because they're on the front lines, and they're going to catch everything
Mm-hmm.
that comes in front of them. But it's fairly frequent that I'm either the next step before we go to the radiologist, or they'll go to a radiologist with something, and then together they bring it back to me. So fairly frequently in the conversation with the radiologist too.
Okay, good. So Manny Canal has a saying that he is pretty well known for, and I think it's easy to say no, but it takes knowledge and the willingness to apply that knowledge to say yes. I think we can all say we've heard that several times. What do you guys feel like is the biggest challenge when it comes to saying yes? And I want to circle through everybody, but I'm going to start with David Altman, because you brought up a really good point. Being the MRMD, I think, has some complexities to it, meaning you're captain of the ship and you're running the show, but you also have to run that show in agreement with management of the facility too. Can you speak to that? Has that been a challenge, or have you had anything hurdles that you've had to overcome regarding that?
The sentence I would start with is, we've always done it this way. And you may hear that from anyone in this field, other providers, administrators, even your own mind. It may be referring docs used to scanning certain implants without scrutiny. Certainly sometimes patients too are confused why things are a little different. I never had to change clothes before, something like that.
Mm-hmm.
For me personally, one of the challenges was spending some time educating myself and others in my own radiology group about the changing landscape, especially the changes over the last 10 or 20 years. It's changed a lot, especially for those of us who are a decade or decades out of training. It is a different safety world than it was not so many years ago.
Right.
So even in my own radiology group with other very experienced radiologists, implementation of things like just yearly training was a challenge. Senior radiologists who have done things a certain way and are reluctant to change. And I'm quick to add that this is not evil. Everyone is pro-safety, but particularly in healthcare, professionals are right to make careful, gradual changes to practice patterns. So when something needs to change, it takes time. It takes some patient explaining and persuasion. And I'll add that that's one of the ways that certification really helps with the existence and backing of institutions like ABMRS, and the ability to say that you or your colleagues are credentialed in one of these ways. It really helps to have these defined roles, and it can be easier to explain to your local colleagues that there is an evolving standard of care.
Yeah, I think, Kristan, you've been in this field for years now. You've probably seen a pretty big evolvement of it too, from a technologist standpoint. How do you think that having credentialing impacts that part of it? Whereas, do you think that working with technologists who are not credentialed, do you see a difference in maybe technologists who are credentialed?
Absolutely. I think that the just awareness of safety is so different, and it's not that people don't want to be more safe in the environment. Sometimes it's lack of education, and it's not due to their own fault. Sometimes people don't have the resources to get to the education. I realize that anyone can get their hands on books, but sometimes they don't have that support mechanism. So one thing that I especially like to do in the PRN situation, when I was in that situation, was to knowledge share. And I was always trying to explain to people. I've always been someone that if I went to a conference, when I was in leadership management over 4 different modalities, if I sent someone to a conference, I said, you've got to come back and share that knowledge.
Mm-hmm.
So as a credentialed MR safety officer, if I saw something, let's say it was, let's just do tissue expander, because I believe there's 2 now on the market that are MR conditional. So that comes into the department. Everyone always says, no, it's an absolute no. Okay, we get to go to the bathroom. You know how busy, MR is, we might get a lunch break today. It's almost every single implant and device has to be looked up every single time that they come, because not only are new implants and devices released every day that are now MR conditional, such as these, tissue expanders, but they go back and they do testing, and they go from MR unsafe to MR conditional at 1.5 and 3T with these huge, B1 plus RMS levels. And so it's almost like the MR safety officer should be a completely separate role. And I understand that's not
the reality.
In all situations. It's not. Well, and I've been to facilities where they have 2 in a relatively small situation, and the facility runs. So open table time, if you think about it, so part of my background is business as well. Open table time, you're losing money.
Exactly.
If you're continuously keeping a patient on the table because you have smooth running with an MR safety officer, and I can see both Dr. Dave Altman and PhD Dave Jordan nodding their heads. If you've constantly got a patient on the table because you have a smooth running department, that is efficiency.
Yeah.
And that is what you really need. So it doesn't cost that much to have a position of a true MR safety officer that keeps the things going and running smoothly. So that's my opinion, but I do see maybe a little bit of backing there.
Oh, I back that fully. I think you can't afford not to have an MR safety program. Think about, like Dave Altman said earlier, think about all of the patients that you potentially, or maybe you said it, Kristan, all of the patients that you would potentially say no to who you could have said yes to, and the implications that come with that. So Dave Jordan, what about you? Maybe you said it and I'm not recalling it. How long have you been in this role as the MRSE?
Well, almost 10 years.
Okay.
And I think informally for a little while before that. So, before we had this thing that was called an MRSE, it was, like Kristan said, you call the physicist, or all the weird questions, and especially if we might have to do some math.
We got a formula.
but I think, it has been about that question that, that you brought up about how do we get to yes, because I think it is very common for a lot of different reasons, and every department has their own culture, but I think there are certain places where that culture is extremely risk averse. And so, it's why would we risk something bad happening, out of balance with that consideration of, well, what is really needed here for patient care? And that becomes a very difficult conversation when you're left with some uncertainty. And how do we pull this apart? And how do we really balance those things? And how do we get to the right answer if we're talking about benefit and risk in context? So
I have a question then. So I just was retained on a legal case, and so this would go for both Dave Squared. I'll just say Dave Squared for this one. It's delay in care because they absolutely could have done the patient. And so what's your opinion on that? When you absolutely can scan the patient, no problem whatsoever, and there's a delay in care, and there was the patient was paralyzed because of a spinal cord stenosis.
Of course, I'm not not even a medical legal expert.
Okay, I just do expert, you know my role. I just, I'm the tech.
I have heard that, in dealing with certain cases like that, you have to be able to establish certain things like, cause and things. I really don't know a lot about it, but I can say what we all do know about it is our obligation to provide good care. It sounds so simple, but it's really a big deal. It is important that we stay up to date on the training so that we can do the right thing when they're there. If you need to scan an emergent MRI of the lumbar spine for like suspicion of epidural abscess, you're always balancing benefits and risks.
And this was about an implant, and it was an active implant, but it did have conditions of use, and it was perfectly fine. But the easiest thing to say is what we just talked about. What's the easiest thing to say?
No.
Correct. They said no. And so, that's what we're talking about here. That's why we need all this credentialing and all this, special attention. And I think Dr. Altman, you said annual training. So annual training, we just had this, 2024 document. Woo, the 2024 document, came out. And, so now, I'm having to update all my training, with Bill and doing all of that, just to make sure that's completely up to date. And then we'll deliver that to, the same groups, new groups next year. It's important to keep all of that up to date and continuously adding different things to all of the different types of education that we do to try and make sure that we keep everything as relevant as possible. And to keep people, there's a group in a few weeks that we go to every year, and they say every year it's different. You're always, tweaking it. You're always bringing different things to our mind that we didn't think about last year. And that's my responsibility and Bill's responsibility to always keep them thinking on their toes. What else can we show them that we've seen? Because we're exposed to so much. If you think about it in our roles, and Kellye, you're amazing as a part of my MRSO ESC. I just have to always kudos to you. You are just so critical to my ESC. I really appreciate you. Just a little shout out there. But, I think that it's just really important, being able to do this and to share this important information, because we as a whole go to these conferences, we speak at them, we see the most relevant information. And so again, we have to knowledge share.
Yeah. I'm gonna tell on myself a little bit on how long I've been doing this. So I started in MRI, I think in 2011, and I didn't get my MRSO certification until 2019. And then I got my MRSE certification in 2022. And I started MR in a time, at least I'm in Tennessee, we're on the East Coast, and maybe things get here a little bit slower. I have no idea. But when I started as an MR tech, we didn't scan pacemakers. There were still the signs on the door that had a pacemaker and it was a line through it. And it was like, no, you're not going to do that. And right before I sat for my MRSO board, there were talks of, we're going to start scanning pacemakers. And I thought, oh my goodness, if we're going to do this, there has to be some sort of implication to this. And how do I get all the knowledge that I can get to maintain these patients' safety? So what I found from sitting for both of those boards, the MRSO and the MRSE, was that I learned a different way to think about MR safety or to think about MR. I know you guys are all seasoned. If you can think back to a time before you had your certifications, what is the biggest takeaway that you got in studying for or sitting for a board or gaining a certification or credentialing? Must have been a good question.
When I started as a patient care tech aide, and so I just did I cleaned up vomit, changed coils, and screened patients. And I always saw people taking the wheelchair, the Ferris wheelchair, to the end of the table. No, this is back in 1993. I mean, I know
shielded rooms, right?
Right. Literally, I mean, we had 4 buffers. I'm from memory. I mean, everyone knows they got 4 buffers in the magnet. I mean, we were just notorious. It's like we left the doors open for them. And so I literally one day I just thought, I'll go ahead and take the patient in. And I didn't know. I didn't really pay attention. They always stopped at the end of the table. And so, then, someone came running and, leaped on my back and stopped me. I mean, so I literally was on the job training, and there was 4 techs in MRI at Emory University Hospital when I started. There were 4 technologists and 2 magnets.
Wow.
And so I knew nothing about safety. The only thing I knew to ask them, about brain surgery, I knew that aneurysm clips, all of that was, the pacemakers. I knew to just, pound away at those types of things. Retained leads. I mean, there were certain things that, I had a fantastic, lead supervisor there. She was there like 43 years, but she couldn't be there 24 hours a
Right.
day to oversee me and my stupid little mistakes that I was constantly making. And so, just my evolution and being able to admit that I have had near misses. I have truly, it doesn't matter how educated you are.
We're
I
human.
literally, I am human.
Mm-hmm.
I have had skin erythema before, caught on the scalp of on a patient with I did FMD, I did everything, but it was ironed in those the leads that you have on the for the EKG. They were ironed into a gown, and they weren't caught. But I pay attention to my patient on the scalp, went in, and was skin erythema. And let me tell you, it was taken care of, it was fine. But if you don't pay attention to your patient, or they're sedated or something, anything like that, and in a children's situation, a lot of times they're sedated. I got really lucky.
Yeah.
But I can admit that I made mistakes. And when I do any type of education, I say, don't raise your hand, because I'm pretty sure it's everyone in the room.
Yeah.
Everyone's had a near miss.
Yeah.
Now, but then you ask how many have reported it, and it's always no. And so I think there's a very poor reporting mechanism. And so, I wish that was more accurate, so we could see more accurate data and less anecdotal information, because we hear, things have gotten better, but we don't have the hard facts.
Yeah.
I will tell you that Mayo in Rochester, they have a fantastic reporting mechanism, and they have follow through, and they can show you metrics. And I think that the way that they handle things is absolutely phenomenal. And I think that probably if they had 90 techs, I think 50 of them are credentialed.
Wow.
And so it does work. It's an unbelievable number. I don't know if somebody else knows their number, but it is like crazy how many of their techs are credentialed. And the way that they handle things, the follow through is phenomenal, and they really, they don't make mistakes. So that's the goal.
Yeah.
To me, that's the standard.
You're right that when we say experience, we think of experience as often a good thing, and that experience is often experience of mistakes that we have all made.
Yeah.
Your stories about the earlier times, you asked about times before credentialing, and it made me remember in my training that we were simply taught a few lists of things like aneurysm clips, pacemakers, cochlear implants, and we just learned those as no subtlety or nuance to it. I do remember a time well before that I got involved in this field, probably late 90s or early 2000s, I was in an MR suite with several people as some level of trainee, helping with an MR procedure. And I was standing right at the edge of the bore of the magnet. No one had screened me. I had walked in there without changing anything about myself. And I was trying to focus on the patient, of course, but I was frustrated because I kept getting interrupted. Someone kept pulling my left arm to the left towards the magnet, and it happened 2 or 3 times. I kept pulling it back because I was very focused on the procedure. It turned out that I was wearing a watch that had metal on it, and it was getting moved towards the magnet. I had no warning or screening before I walked in there. I am now much more careful.
Mm-hmm. I agree with your statement, though, about we always think experience is just years that we've put into this, and sometimes our mistakes are the greatest teacher. What about you, Dave? Can you think of maybe how things have changed since your time before credentialing?
I mean, there's much more awareness than I think. I mean, I grew up in this, listening to lots of different folks at conferences and things, and when people were just becoming aware of this, and it was really becoming a field unto itself. And it was always the big surprise. Like, oh wow, this is people are having. You started to hear about the floor buffers all the time, and
Mm-hmm.
I think everybody's had a floor buffer, and everybody likes to think they're the only one that's had a floor buffer, and so they should be embarrassed about it. But people are talking about it more, and I think to Kristan's point about reporting things, that's a lesson. We know that from all across any type of safety in any type of setting, that you have to do that reporting. You have to learn from those things, because no matter how far you get into this, and no matter how much you know, and no matter how much you've seen, the next thing is always going to be a surprise. And so
Mm-hmm.
the more of that experience you can share with others and get from others, the fewer things are left out there that will surprise you or that you're not prepared for. You'll still be surprised, because somebody will always come up with one more weird thing. And it's funny when I give talks about this. I'll talk about things that were surprising to me 15 years ago, and then I'm surprised that so many people in the audience gasp and haven't heard about it before. And I'm like, doesn't everyone in MRI know at this point that patients put nail clippers in their underwear? Like, isn't this just something that everybody has run into? And people still gasp and look shocked. There are still surprises. So, expect to be surprised, and then be ready to roll with those punches, because it's always something
Mm-hmm.
new.
Yeah, and I think always be willing to learn something new. Like I always think, oh man, am I ever going to know everything that there is to know about MR safety? And the answer so far for me has always been no. Look, there's always something to learn. I think one of the biggest challenges that I have seen with regards to MR safety is we're at a place in time where safety has evolved. Even if I think back to when I first started, like we weren't scanning pacemakers, and even coronary artery stents. Where I was, it was like, okay, you can scan them on a 1.5, but you got to wait 6 weeks. And then it was, you can scan them on a 3T, but you still have to wait 6 weeks. And now it's like, you could have had a coronary artery stent put in an hour ago and you can have an MR. But one of the biggest challenges that I feel like I've seen when it comes to MR safety is there's these varying levels of knowledge regarding it, and not just from technologists, but from physicians too. Kristan, to your point that you were mentioning earlier, there are different types of radiologists, and there are also different types of technologists. What do you guys think could be done to get everybody on a more level playing field?
Well, I'll say that there unfortunately are techs that will tell you that they have 30 years of experience, and they're a little bit like, I've got this many years of experience, and we may hear from Dave Squared the same thing, that you get a little set in your ways.
Mm-hmm.
That is Dave Squared, okay? Because we call you that all the time anyway. So okay, I figured. Sorry. That's, anyway, I'm going with it. So, they get a little stuck in their ways. So, I'll see them in an educational setting. I've even had someone say, I learn best with my eyes shut. So don't worry. I mean, literally, I've had someone, listen to me speak, and that's such a compliment when you're starting a talk. It makes you feel really, really excited about this one. I mean, this one's going to go really well with that person up there. They're going to learn a lot with their eyes shut. So because they had 28 years of experience. And so I think sometimes there's just going to be a group that we can't penetrate. But then there are others that are very thirsty for that knowledge. And again, sometimes they don't have access to that. So, what you do is you say, here are some free tools. There's so many free tools that are available to them that they do not even know about. They're like, oh, thank you. And they listen to these things on their way to work. Mm-hmm. You guys offer so much, different things on your website that people can go to for education. A lot of different vendors offer a lot of different types of things that people can listen to. Some that, have accredited CEUs with them. There's all different types of education that's free out there that can keep them as relevant as possible. Mm-hmm. I'll say that I would also tell any MR technologist, always stay humble. Always, if someone called me last week, I was going to volunteer at the kids' school, and I said, last time I checked, it was a 30-minute scanning tapping time within a 90-minute window. I said, but that was yesterday. It could have changed. You have to look it up. And I know that sounds like a weird condition of use, but there is an implant out there that's an active implant. That's a 30-minute tapping time within a 90-minute window.
Mm-hmm.
There's probably 15 different implants like that out there. And I said, but you're going to have to look it up. Do not take my word for it. I'm not giving you approval. You have to look it up.
Mm-hmm.
So you always have to keep researching things to stay up to date. You can never, ever just, in the South, I guess we say, sit on your laurels. You can never just, relax about it.
Mm-hmm.
And so you need that type of thirst. And I think in MRI, there also is that personality. Anyone that chooses MRI, it's always someone that seems to want to know different things, because it evolves so much.
Yeah.
Think about from whence we came. I mean, from 1993. Okay, so I guess I'm at 31 years. I mean, that's pretty sad, actually. That's scary. God, can we just lie and say 1997 or something?
We'll omit that part.
Let's take that part out. From once we didn't even have the gradient strong enough to do diffusion. We didn't have diffusion when I started, so we didn't have flare. Just thinking about how far we've come with pulse sequences, how far we've come with everything. Safety has come so far, as far as that. Implants and devices have come so far. We have to go with that, and you cannot stay stagnant. So you've got to make sure that every technologist that I work with, that we all work with, that Dave Square work with, I'm sure they do the same thing. That's our jobs. That's our role in this, part of this board, part of this community of credentialed individuals. I believe that's kind of what we take on once we become credentialed, in my opinion.
I agree.
I would also add, not only is there an obligation to do this, whether you get certified or not, there's an obligation to get current so you can do your job well. But I would also want to emphasize the positive fun part. I mean, that's positive too, but the actual idealistic, optimistic, fun part of doing this, that anyone can get involved and make a big difference locally. Yeah. And speaking from the perspective of a career building for a young physician, or really anyone, when you join a group, it's really helpful to kind of carve out an area of subspecialization, your own little niche, besides showing up and doing a good job. What can you bring? What are you the go-to person for? And for me, well, I was not going to be the social chair of my practice, but this is a great way to get involved with a clearly defined role, a focused area of expertise, and it makes you valuable to your institution. You're bringing better care. You can be a problem solver, a local expert in something that comes up all the time, every day. And you can also improve, you can help the hospital system with efficiency. We talked a little bit about saying no and missed appointments. There are fewer imaging slots that are turned away with knowledge of this. And it is really not only helping the institution, it is truly helping patients, both with individual cases and at the policy level, so they can get scanned. So it's a great niche of expertise you can inhabit at your local institution. And the good news is that you do not have to invent it all yourself. There is great information out there, even better than a few years ago, even better than 10 years ago. And you can get certified through the institutions like this, ABMRS. You can be the local expert.
Yeah. I think what you said is super important, Dr. Altman, that, the reward, how rewarding it feels to be able to give that patient care who so desperately needs it and who's been turned away at so many other facilities. And then not even just how rewarding it is to be able to do that, but to be able to do that safely, to feel confident in putting that patient in the scanner and knowing that you're mitigating those risks. I don't know, for me, if you get into this field, it's likely that you care about people and you want to provide good care, and being able to do that, to me, it's just a very rewarding feeling.
Yeah, seeing that smile when you say, no, we actually can scan you.
Mm-hmm.
No, it's going to be fine. And then just giving them that, no, it's going to be okay. We're going to be able to do this. And they're like, what? You can actually, yeah, absolutely we can. Yeah. And then they're just like shocked. People have turned me away. I haven't been able to be. No, we can. It's okay.
Yeah.
And then you do it and they're shocked. And that is a good feeling that you're able to provide them something that MRI is going to be the modality that's going to give the best diagnosis according to what the radiologist has requested.
Yeah. So I'm going to switch gears here just a little bit because I think this is something that we have to touch on at least. Remote scanning is coming our way. Like it or not, I don't know what everyone's opinions are, but I'm sure we'll find out. I guess that's a good place for us to start. What does everybody think about remote scanning from a safety perspective?
Well, I can say it's easy to be concerned about it because an initial reaction might be, are we compromising safety standards by not having someone in the room? But particularly, I mean, not having the direct scanner in the room. Of course, we have somebody there at the suite, I should clarify. But I would look at it also from a different perspective in that, especially in this era of personnel shortage, it can allow for more and better types of advanced examinations to reach people that need them. So it is not, I would not look at it as a compromise, but a way to best deal with finite resources to get people the care that they need. It is complex. There are a lot of questions that do and will come up, and it's evolving. But you can look at the updated ACR, MRI safety guidelines, and it is explained there with some examples of some common scenarios. So I would encourage folks to go check that out.
Just the ACR manual on MR safety in general is a really good resource if our listeners haven't checked it out. Kristan, Dave, what about you guys? What are your thoughts on remote scanning from a safety perspective?
Well, I've traveled to a lot of facilities that are doing it, just kind of a journey. I was asked actually to speak next year at the SMRT for the ISMRM in Hawaii on this topic, and I've spoken on it, AHRA, a couple of different places, and just kind of explored it from all different people that have created their own ways of doing it, different vendors that are doing it, and facilities that are doing it. And it can be, I'm just going to tell you, it can be absolutely, it can scare you beyond belief. I mean, it absolutely can. I went to one place and the guy literally had 8 screens up and nobody was being changed, and nobody at all. And so I'm back there just wanting to pull my hair out, right? And there were several other people with me on that trip. Another trip I go to, and the techs got there, 6 screens up, only 2 patients. No, that tech was only doing 3 patients, but one was an abdomen. Okay, at the other facility, they had a ton of screens up because they were looking at other things as well. So it wasn't like there were 8 patients being done, but a lot going on. Okay, and then the patients weren't being changed. That's the previous facility. Then I go to another facility, only 2 patients being done, constant communication. Patients are all changed, and level 2. Completely trained tech aid on the other side. That is, any questions are being escalated, and the patient's not going on the table until the appropriate time. And just it's very, very flawless as far as how things run. So I think it comes down to not just policies and procedures, but those being actually followed to a T. And, the roles being very well established and no deviance from that. Mm-hmm. And so, I've worked with sites that say, we're so huge and we're having to shut down facilities, but I know this group of radiologists will not change their patients because they have to have such throughput, but this group of radiologists will allow you time to change your patients. And so it really is going to vary. And there are a lot of obstacles, but there are going to be roles in place coming up that hopefully will help out with that.
Yeah. Dave, do you have anything you want to add?
Yeah, I mean, I don't have firsthand experience with this yet, but I know that, thinking about it from the standpoint of the physical location of the magnet, I'm trying to think about this and trying to talk with colleagues about this from the standpoint of what are our sort of non-negotiable outcomes. So however we do it, whoever does it, however we kind of slice up the roles differently from what's been done traditionally with our technologists physically in the same location, what are the things, what are those red lines? What are the things we have to absolutely make sure that our approach satisfies however we do it, and use that to sort of guide, yes, we'll do it this way, no, we won't do it that way. But I think that having addressed all of those non-negotiables for safety, as Dave and Kristan have said, there is a big opportunity there to get creative with addressing staffing problems and to maintain patient access and to create more uniformity of higher quality services across a wider range. And health equity is a big issue right now. So how can we reach more patients where they are, get them in for the care they need? We just can't do it without getting creative with our logistics. So that's sort of how we're trying to frame our thinking about it here. As we're approached by different opportunities, different companies, and looking at the technology, and I can imagine a million ways this could go terribly wrong. Just starting with the short list of things that Kristan described, having actually seen. So we don't want to be one of those stories.
Mm-hmm.
So I'm trying to say what are those things that we will not compromise on, and what are those things we'll absolutely make sure, so that at a basic level, we have the critical safety infrastructure in place as we move it.
Yeah. So in the last episode, Bill mentioned the MRST credentialing. Do I have that correct, right? MRST? Yes.
Yes, that is correct.
Okay.
That's the project code.
Is that something you guys want to or can speak to?
I can. I don't know if anyone else wants to start off speaking to it. Dave Squared?
Go ahead.
Go for it.
Okay. All right. So this is something that Dr. Canal is spearheading. He asked a group of us to be on the exam specification committee. And so there's a group of us that are working together. It is the MR safety tech. So it is not a tech aide. It is a separate role, and it is for the MRI department. So it is an MR safety tech that is credentialed by the ABMRS. The exam is not out yet, but we have a 3-hour meeting coming up with Dr. Canal. We are working diligently to try and make that, bring that to fruition. And I do not have a timeline on when that's going to happen. But it brings a couple of things to mind for all of us to think about. A lot of people think, does this replace my role as a technologist? Well, think about nurses and then LPNs. Kind of elevated a nurse, right? And then you've got the help with an LPN, right? Think about it in terms of that. So you've got this MR safety tech. So they're trained to the highest level. The only thing they can't do is scan. The only thing. So the technologist is responsible now just for the scanning part, which they can do remotely or they can be on site. It doesn't matter whether we're talking about just remote or we're talking about at the facility. But then they've got the MR safety tech, which is their credentialing and their role. And this can be students, this can be x-ray techs, this can be someone that used to work at any place, down the street from here, making subs or doing it can be any type of person that gets this training and comes in to this level and gets this credentialing. And then it kind of elevates the tech to a higher level. So no one should take it as any type of infringement or, is this coming in and taking any type of place of what I do? No, it's just the evolution of what needs to happen.
Mm-hmm.
Because last time I checked, we were at 81% capacity of MR techs, and that's actually dropping. Less people are going to MR school, correct? And over the next 25 years, the number of exams is going to more than double requests, correct?
Yeah.
So if you do the numbers on that, we're going to need these MRSTs. So
Mm-hmm.
Dr. Canal is brilliant coming up with this. And then I'm very proud to be part of this group coming up with this exam. And I think when you look at the people that are currently applying, when I go to facilities for the types of positions to be support personnel in MRI versus the number of people that are applying to be technologists. So my fingers are on top of each other here. This is the number of people, let me just invert it, that are applying for technologist positions versus the stack that are applying to be assistants and help in MRI. And they work very hard in almost all situations. Wouldn't it be great if they were elevated to do everything but scan and allow the technologist to concentrate on the patient, which is what the ACR wants, verbal and visual. Have we ever truly been able to do that as a technologist? Kellye, I'll let you answer that one.
No.
Okay.
we're
that's
spread very, very thin, and each year it's like more and more responsibilities get added onto our plate.
Yes, and that makes things scary. That's where that Swiss
Absolutely.
cheese model comes in. So I don't even know if I addressed it very well, but that's where we're headed. And Dr. Canal is the person, like I said, over it. So kudos to him for coming up with this idea. And again, I think it elevates the technologist, and I think it would be great to have someone supporting me. I'd be super proud to have someone that is credentialed in that capacity.
Yeah.
That would be a support personnel for me.
Yeah. And we talked a little bit about throughput and efficiency. Just imagine if you've got someone who's safety trained, who can, while you're walking your last patient out, they've got your next patient screened and they've got them on the table in a safe manner for you. I mean, I don't know how much better throughput you can get than that. Now I don't have to wait that 15 minutes to get my own table set up and screen my patient and put them on the table. I think it's brilliant, and I'm excited to see what comes out of that.
I'm not as familiar with it as Kristan is, but I just want to speak to the value of why credentialing is important and the need for standardization of things like safety training for all of us, for support personnel, but everybody who works in healthcare. And, when the ABMRS was formed, the number of MR accidents, they say, in the U.S. was climbing at a rate that exceeded the rate of growth of MR examinations, not the absolute number, but the rate was growing faster. So there's been a move to establish standardized MR safety practices and to formalize MR safety roles at the individual institutions, as we know. There's a lot of great material out there to study. The ACR manual we mentioned, there's great articles and books, there are great courses to take, but until the creation of the ABMRS, there was not a standardized way to assess and document this training. So I'm speaking not only to the help that it gives the institutions, you mentioned the throughput, but also the value that it gives to the individual. The ABMRS is not creating policy, but we're looking at standards and generating and maintaining and certifying an examination, and that's something the individual can take with them. It's because this is standardized that this is something different institutions will increasingly recognize and something of value you can bring with you wherever you go.
Yeah.
It makes you proud. I'm proud that I'm credentialed. I truly am, because, well, I had already given, I had already done a safety talk in April of 2015, and I had not taken the credentialing yet, and I was not on the board. So I was so afraid when I went to Las Vegas to sit for the first boards that I was going to fail, and I had already done this 4-hour chunk of MR safety education. I was like, if I fail this first exam, I'm going to feel horrible, that people are going to think I'm the dumbest person in the world. And then I joined the board, I think maybe that year or the next, I don't know, it could have been 2 years later. I have no idea how long
Kristan,
I've been
if you
on
failed the examination, that means the examination would need to be changed.
You were so kind, but no. But I mean, there was such a sense of pride when it's like the big envelope versus the small envelope type of situation. I mean, I don't know if anyone remembers that, but when you certain times, if you get accepted to Duke or something, they give you the small one. It's nope, sorry, next time maybe, forget about it. Or if you get the big envelope, right? And so that's what it was for me. I didn't sleep for 3 weeks. And so, I just am so proud that I'm credentialed, and I'm proud to be carrying it on and keeping the questions updated and relevant, and, working again with all of you on the board to make sure that happens.
It's really important. Of course, I was, joking about that, but that reminds me to emphasize that not only are there a lot of great professionals out there that are credentialed, but I believe all of the people that are on the board working with the test have gone through this same credentialing process, like you were just speaking to. So I think it speaks to the commitment that folks have.
I'm very jealous of the people who are taking the electronic testing now. They'll never know what that 3 week period feels like, and getting into that email and looking to, and your heart racing, thinking, okay, have I passed this or have I failed it? They'll never know that feeling. They'll get it immediately. So I'm very jealous, but I'm glad that the ABMRS has done that, because I think that gives more people the opportunity to sit for this test. It's not as exclusive now. We're saying, hey, like, if you can find a prometric testing center, go test, go take it. Do you guys have anything else that you'd like to add about why you think credentialing is so important?
You made a good point about the Prometric, though. You can find a testing center. I think there were like, I went when I was in a wheelchair, and I was able to find two within 8 miles in either direction. So I was the handicapped person that went to go take it. They took perfect care of me. And someone went in Canada, and we had people go all over. And I think none of us had any issue finding a facility that was close to us. And I think you made a great point there. Access to taking the exam is 100% there for almost everybody. I think everybody across the nation.
Yeah. So no longer a barrier to testing. It's no longer like time and travel and hotel and flight and all that. It's just drive down the road and take it. What, David, you were starting to say something.
Oh, well, it's echoing the same thing that y'all were saying. Or I can say this, the field of MR safety, magnetic resonance safety, is changing. And we know from physics that a changing magnetic field is an electric field. And that's one of the reasons we've been so happy to move to electronic testing. That's a little MR physics. But in all seriousness, I would direct anyone interested to go to the website, ABMRS.org, for the most current information. That transition to electronic testing that you mentioned, in case folks aren't aware, it's occurred recently over the last couple of years. It's currently offered for all of the examinations. There is no paper testing anymore. It's MRSO, MRMD, and MRSE electronic through the Prometric testing centers. There are hundreds of them. It's currently being offered in the U.S., Canada, UK has started, and we're hoping to expand to more places. And I will just say another word about recertification. The ABMRS offers 10-year credentials, and the first examinations were around 2015. In MRI, sometimes we talk about time varying fields, but time is not varying for all of us. It keeps passing right on by. It's another MR physics joke. And believe it or not, we're in 2024, almost 2025. So we've reached the time when the earliest certificate holders may be beginning to think about recredentialing. And just like you said, the good news for those folks is that with this move to electronic testing, it is more convenient for both time and location. There's no single test date. You can sign up for a test date anytime at your convenience in a testing center convenient to you. There are hundreds of locations. So not only easier for people taking the test, but also recredentialing. And for new candidates, we hope that it'll expand the number of people that get involved. So begin the sign-in process at the website, abmrs.org.
Great. Yeah. Thank you, David, for that. Dave, as the vice chair, and my understanding you're about to step into the chair role soon, do you have any closing remarks?
I just, to echo what Kristan and Dave said, I mean, this is a really important way to get the yes for more of our patients for the care that they need. And so, I think everything that the board is doing is focused on that goal, right? So we want to get more people credentialed. We want to open up support for this new MRST role, which I think is going to help remote scanning, but it's going to address other things too, right? So again, how do we decide that somebody is ready to step into that position and to be able to give meaningful help to our technologists, whatever they're, wherever they are. All of these things are really aimed at making this whole process more accessible, cutting out these things that don't add value, like spending time and money on travel, and just getting more people involved in these programs. So, and I'm very, very fortunate to have a big group of very passionate and very dedicated people that are working on it. So as you see and hear from two of them here, and there are many others, so it makes my job very easy, because get together with all of them and hear all their great ideas and their energy. So
yeah, it's contagious. Hopefully MR safety will continue to be contagious with technologists and physicists and radiologists alike. And after listening to this, they'll be like, you know what, I should go get credentialed. Thank you guys, Dave Squared and Kristan, for joining me today. I hope you guys don't mind if we call you that. That might be your nickname.
Oh, it has been. No, it has been. That's what we've done. I've had to do actually. Maybe I'm not sure who coined it, but probably Bill.
It's gonna stick now. Well, thank you guys so much for joining me. It was so insightful, and I'm sure that our viewers will think so as well. And for everyone listening, be sure to tune in to our third and final episode where Toby Gilk joins us to talk about MR safety from an expert witness consultant perspective. Thank you guys for tuning in.